Okay, so we are live now at the moment. So we haven't started yet, but we are live. So just to let everybody know. So we've got Prof. Amjad Travails from Pool, David Nasrallah from Royal Free, and then obviously we've got Fahad Shah here, Shaukat Khanam, Dr. Shahid Khattak, Shaukat Khanam, Professor Tariq Latif from Shaukat Khanam, and myself. So I think we've got about 3-4 minutes before we go live with the audience. Is there anything anybody wanted to ask before we start?
Oh, not particularly. Nice to see you all.
Nice to see you as well. You lost a lot of weight, Prof.
No, I didn't. I didn't become COVID positive.
Oh, I hope you're better now.
Yeah, no, I didn't become. I said I was not positive, so it's not the reason to lose weight. That's what I'm saying.
Okay.
And is it still
Prof.
to go first or second?
David, were you saying something?
Yeah, is it still possible for me to go earlier, sort of first or second?
Let me just ask. David was asking if he could go first. So yeah, we can put you on second if you want. Or do you want to go first? Assalamu alaikum. David, do you want to go second or do you want to go first?
Has he muted his speaker?
Yeah, I muted his mic.
Sorry, I was sorry about that. I was on mute. I was just saying it may help my stress if I go first, because I know they're anesthetizing the patient. Well, they've started anesthetizing about 20 minutes ago.
I'll ask Prof. Prof, would you have any?
No, it's okay. No, we appreciate it. It's absolutely fine, David. You go ahead.
Thank you very much.
No problem.
Okay. Okay, fine. So we'll go first with David, then with Prof, then Dr. Khattak, then Prof Latif, and then Fahad. Okay, fine. So you've got 1 more minute, and then we can start. मैंने presentation कहाँ पे share करनी है? Yeah, अजय मेरी presentation share हो रही?
Yeah, we can see it now.
Okay, perfect. Thank you. Okay. Right, we're going to start. Welcome everyone to this second webinar from the surgical department based here at the Shaukat Khan Memorial Cancer Hospital. We are going to talk about the travails and triumphs of providing surgical oncological services during these testing times of COVID-19. Now, it's been a few months since the corona pandemic has started, and the world has had quite an experience with it. Over the past few months, over 8 million people have been infected, and more than 456,000 and counting number of deaths have been reported worldwide. As you can see from this map that we've got here, there's no place on this earth which hasn't been affected. Some more than others, especially if you can see here in the subcontinent, there's some big red dots there. Now, this has caused a lot of challenges for the surgical community, especially those who are providing cancer care, because this has allowed us to deal with unique challenges that come along with this. We have to mitigate the risk for our patients, both in terms of the extent of surgery, as well as saving them from the effects of the virus. But we also have a responsibility toward the healthcare professionals which are involved in providing care, such as our assistants, scrub nurses, and so forth. This goes along with having to prevent post-operative complications for these cancer patients who are usually malnourished, immunocompromised, and so forth. And then we also have to deal with the logistics of provision of protective gear and so forth. So over the months, different units in different parts of the world have had different experiences. And the only way we can deal with this pandemic going forth is to share that experience of each individual country with each other, so that we can learn from each other and provide the best possible care for our patients. And that is where this webinar is coming in. This is following on from a last one where we shared our local experiences from Shaukat Khana. And now we want to kind of tally that up with what's been happening in the rest of the world and see if their experiences have been similar to us and whether we can learn from each other. I think this is an important, from our side at least, an important 1-hour webinar where I would introduce the speakers, which are very well renowned in their respective fields. We have Professor Amjad Parvez Chima, who's a consultant colorectal and robotic surgeon from Poole, UK. He's also a robotic lead for Shapalimard Foundation in Lisbon. We have Dr. Shahid Khattak, who's a consultant laparoscopic upper and lower GI surgeon, who's working here at Shaukat Khana Memorial Hospital. We have Professor Tariq Latif, consultant pediatric surgeon, who's our pediatric surgeon here. And prior to joining us, he was head of department for pediatric surgery at Sherzad Hospital. We have joining us is Mr. David Nasrallah, is a consultant HPB and liver transplant surgeon from Royal Free Hospital, London. London's been one of the most affected areas in the UK, so it'd be good to know what his experience has been. And last but not least, we have Mr. Mohammed Faj Shah, who's a senior instructor in colorectal surgery here at Shaukat Khana, and he will be talking to us from the trainee's perspective. Welcome everybody, and thank you for joining us. I would like to start with Mr. David Nasrallah, who's from Royal Free London, because he has to go off to do a liver transplant in the kind of immediate future. So we're going to start with him first. So there's a slight change in the order of the speakers. Apologies for that. So Mr. Nasrallah, welcome for joining us.
Hi, and thank you very much for inviting me to take part in this. It's much appreciated.
So London has been one of the most heavily affected areas in the UK from what we hear in the news. What strategy has the Royal Free adopted for the hepatobiliary provision of services in that catchment area?
So quite early on in the pandemic, there was a strong feeling that doing major surgery such as HPB surgery in patients either with COVID or at risk of COVID would have a detrimental effect on our morbidity and mortality outcomes. So across North London, the North London Cancer Network was put in place and put in place new guidelines to actually determine which patients should be considered to take forward for surgery given the risks of COVID. So actually from early on, we made our operating criteria or resection criteria a bit more restrictive. So tended to only go for fitter patients and slightly younger patients. We also identified hospitals that were considered clean and dirty hospitals, and all elective hepatobiliary operating across London has been moved into these clean hospitals. In practice, what that involved was the British government taking over a lot of private hospitals and using them for public health provision. And then within those private hospitals, we've put in place a system of testing that has sort of been continuously evolving as our knowledge about coronavirus has changed. But in its earliest form, it simply involved patients coming into the hospital, patients for hepatobiliary resections, coming into the hospital about 48 hours pre-operatively, having a COVID swab and being kept in isolation until the COVID swab results came back. And provided that swab was negative, they then proceeded on to surgery. And I know that in the hospital we've been working in North London, which is in North Central London, that hospital has become the clean site for all of hepatobiliary surgery across North London, as well as almost all colorectal surgery. And out of, as of last week, I know, out of more than 700 patients that were taken forward for resection, only 2 came back with positive swabs, both of whom were then sent home and came back 2 weeks later for their procedures when their swabs were negative. And out of the remaining patients, we haven't seen any patients subsequently become COVID positive after having their surgery. So the system we've put in place does appear to have worked. More recently, as the British government has eased their COVID restrictions and people have started going out and about more, I think the restrictions we've put in place for people going towards surgery have become a bit more restrictive, in that they're now expected to self-isolate for 2 weeks before coming in for their operation. And then again, they have a COVID swab on coming in. But those, broadly speaking, those are the arrangements that have been put in place across much of London to keep providing hepatobiliary cancer care.
That seems to be what we've been doing here as well, and that's good to hear that the guidelines seems to be working for you guys as well. Now, you mentioned that you're quite careful in your case selection and you're going more for younger, fitter patient. What about those patients which are being refused surgery and they're not in the younger, fitter group? What are you doing for those? What are the adjuncts that you've been using for those patients?
So I should say, right at the start of this pandemic, we became very restrictive in who were the patients we took forward for surgery. And then as we started to see that our strategy appeared to be working and we were having acceptable outcomes, we actually relaxed those guidelines. And so we've now started operating on almost all the same patients that we were operating on previously. Initially, we identified some patients who we would not consider for surgery, and it was a little bit arbitrary. But we initially said those who were aged over 75 or had a poor performance status or significant comorbidities, and also those patients with poor tumor types such as cholangiocarcinomas. We were deferring them. For patients with colorectal liver metastases, the initial plan was actually to put all of them forward for adjuvant chemotherapy to temporize them. And so in the first few weeks, the main patient group we were operating on were either intrahepatic cholangios or patients with pancreatic cancer. But as I said, as time has gone on, we have eased things up. We've started doing some neuroendocrine tumors, more colorectal mets, and so on.
Now, taking that forward, now as you have started to operate on more and more patients, some of them who have tested positive for COVID and may have been asymptomatic, have you seen an increase in the complications from these hepatobiliary surgery, and has there been a significant increase, or there's been a marginal increase in your experience?
So actually, in this clean site where we've been operating, as I said, we haven't actually had any patients subsequently become COVID positive. And actually, I'd say our morbidity and mortality has been very much comparable to that in the Royal Free. Albeit, I should also say our volumes are slightly less. We're probably doing about 60% of the volumes we were doing previously. And it probably is a slightly fitter patient group. But we certainly have not seen an increase in morbidity and mortality. In the Royal Free Hospital itself, where this hospital was designated a COVID surge centre by the government. So we have had a lot more COVID patients here. From a hepatobiliary perspective, where we've been doing emergency surgery, again, we haven't seen any COVID-related morbidity. We've kept doing some hot gallbladders. We've done a few emergency hepatobiliary resections, and they all appear to have gone reasonably well. I would say my colorectal colleagues and kidney transplant colleagues have had a slightly different experience, where they have noticed COVID-related morbidity, in particular thrombotic events, because I'd say in our ITU COVID population, I understand that more than 50% of those have been found to have pulmonary emboli, and there have also been quite a few cases of patients with bowel ischemia secondary to thrombosis. And similarly, there have been some complications in either renal transplant patients or also the dialysis patient group.
Okay, perfect. Now, obviously, hepatobiliary surgeries are quite intense and long, and quite stressful as it is. What strategy has been adopted by your trust to prevent the burnout and maintain the team integrity? Because obviously, healthcare professionals are also at risk of getting the COVID disease and so forth. So, have you had any members of your team who've tested positive subsequent to kind of starting this, and how have you guys kind of managed to go around this?
So we're fortunate probably that we're a relatively large hepatobiliary unit, and given that our activity has gone down a bit, we have had a bit of redundancy. So if someone else, redundancy meaning additional personnel, sorry. So if someone
You're
does,
not taking people out.
other than being made redundant. So if people have become unwell with COVID, others have managed to cover their commitments. So we've had 3 of my hepatobiliary colleagues have been found to be positive for COVID. They all self-isolated for 2 weeks, and actually it wasn't hard to cover their commitments because the clinics have now been reduced. They're mainly virtual clinics. Similarly, the amount of operating we're doing has reduced slightly. The number of transplants dropped significantly. So we've been able to cross-cover each other. We've had some asymptomatic infections as well. So now at the Royal Free, as things are improving, they've brought in place serology testing for all staff. And I even found myself that I've got positive antibodies for COVID, but wasn't aware that I had it at any point.
And you're lucky then.
Yeah, and across the Royal Free, they've said that approximately 1/3 of the staff who are being tested are being found to have antibodies. So I think the disease has been more widespread than we expected in the hospital.
So you mentioned, one last question for you. I know you're on a short time here. You mentioned the urology transplant side of having more mobility. Now you're also a liver transplant surgeon. How has the transplant services been affected, especially the organ procurement system that the UK has for donors? And have you noticed any change in that?
So I'd say all aspects of liver transplant have been impacted. So starting with donors, there was a huge drop in donor numbers as COVID took off across the UK, partly because most intensive care units were filling up with COVID and didn't really have capacity to start brainstem testing. A lot of the specialist nurses in organ donation were redeployed to intensive care. So there was a period where the number of organ donors across the UK dropped to just 2 or 3 a week. That started to pick up now. NHSBT, who are the national organisation that oversee transplantation, they also brought in place guidelines to try and only ensure that those donors with the highest likelihood of proceeding to a transplant would be offered out. So to minimise the retrieval team's exposure to unnecessary retrievals. So for brain dead donors, an age restriction was put in place, I think, of 60 years old, so only donors up to the age of 60. For cardiovascular death donors, it was only those up to the age of 50 were being offered out for transplant. But there was a huge drop in donors. And on the recipient side, a decision was made nationally that only those sickest transplant recipients who had only a small window to get an organ would be put forward for transplant. So we used the UKELD score here, and it was only those with UKELD scores over 60, which probably equates to a MELD score of over 30, would be eligible for transplant or super urgents. So on the donor and the recipient side, the numbers went down significantly. This has again started to ease up in the past couple of weeks, although there are still restrictions in place on recipients. So it's still only those recipients considered urgent or super urgent that are being put forward for transplant. So I'd say nationally, probably more than 50% of the transplant waiting list is not actually active right now.
I hope things get better. Thank you very much for joining us, David. It's a shame you won't be joining us for the question and answer session, but I wish you all your liver transplant.
Sorry, timings haven't worked out as I hoped. But
it's okay. Best of luck with the transplant.
Speak to you soon.
Thank you
very much.
Thank you.
Thank you.
Right. Next we have Professor Amjad Travails Chima, who we were introduced, and we're going to talk about the colorectal cancer experience from the UK. Prof, thank you very much for joining us.
It's a pleasure.
How has the surgical community from the colorectal side responded to the pandemic in the UK, and how has it evolved since it started?
Well, I think you heard some of it from previous speaker, David, and it's very similar to that experience. I remember UK was following Italy, for example, in Europe, and we were about 2 weeks behind Italy. So whatever pictures were coming through Italy had direct impact both at NHS level and more widely on a psychological level of the society. So they were expecting a huge surge and a complete collapse, potentially a complete collapse of health system. So as soon as beginning of March, the Royal College of Surgeons came up with a document which was written to sort of cope with emergency setting only. So all elective were put on hold, and they said that they would be doing emergencies only. And within emergencies only, it was all open approach, which was educated. So all minimally invasive surgical disciplines were put on hold. And with electives out of the window and emergencies being put in place, then there was a rationing of NHS staff, as mentioned earlier. So instead of sort of everybody going every morning to the hospital, they made a rota. So only few people would end up in a hospital setting, trying to minimize the risk of contaminating each other. So I think this is where it started at the beginning, because they were expecting the worst, up to the point that in most NHS hospitals, mine included, they had contingency plan of changing recoveries or the anesthetic rooms, recoveries and operating tables and operating theaters itself in the ventilated beds. So that's why they want to do very little elective operating at all, just to minimize the risk of not being overrun by the capacity issue. So that's when it started in March. Since then, obviously, things all, in a knee-jerk response. You've probably been hearing in the news that in England, sometime they follow everybody, and then by the time they take an action, the goalposts have changed. So in a panic, we ended up setting up huge Nightingale hospitals. One of the big Nightingale hospitals set up in London was 4,000 ITU bedded hospital they put together with millions and millions of pounds worth of money. And just recently now, quietly, they have closed it. And only utility throughout the whole pandemic was they only had 34 patients being treated in that hospital. And they were being asked to move those patients in the last week, so at least they could justify that this has been used. So they had similar hospitals in Birmingham, Manchester, Leicester, with a huge tax money which were not being used. Now they can take a view that this was all in preparation and it's great, it didn't happen. But somebody playing devil's advocate would say that was a bad planning. So here you are, so we had the capacity. Now they're sort of saying we'll keep it in case the second wave comes.
Okay. I mean, there is the risk of second wave coming, like we all know, but we don't know whether it will happen or not, but time will tell. Across the UK, obviously there's been different reports coming from different parts of the UK. And to somebody who's not based in the UK, it seems like there's been a lot of variation regionally across the country. Do you agree with that? And if so, what are your thoughts and reasoning behind this variation?
Yeah, I think at the beginning it was more to do with people not knowing enough. And when people don't know enough about something, they all have their own strategies, opinions, or sort of have an experience based on their sort of limited exposure to whatsoever. So at the beginning, you heard from David, at the beginning, all the pathways recommendations were made at the local level. So, London had, for example, a pathway to deal with their elective practices. In our hospital, for example, we started off isolating patients for 2 weeks, having the COVID test done 48 hours beforehand, and then having a CT scan on the morning of the surgery, and informing patients that if we see any changes on a CT, they might be cancelled. So that's what it started it as an intensive sort of purposes, so to speak. And then within the sort of, now I'm specifically talking about colorectal. So within colorectal sort of surgical strategies, the idea was not to do rectal cancer if you can avoid it, only do colonic, only do things which are either imminently obstructing or locally symptomatic, and perhaps do them with an open technique and not join them. So at the initial part, in Dorset and in Wessex region where I live in Southampton area, a lot of dissections were done and double barrel stomas were brought out. Now, there is no science behind it. Nobody knew whether it was necessary or not. We have created a lot of work. Somebody have to reverse those stomas. There would be a second admission for those patients. But as we become confident that people are not dying because of this pandemic within surgical specialties and staff's not being contaminated, then people start moving the goalpost. Now the CT scan have disappeared. We don't do CT scans anymore. We self-isolate them with the date, and then we do a COVID test, and then you operate on them. And then we have incorporated rectal cancer back into it, minimally invasive surgery have come back over a period of time, and now you are doing what you normally do as your standard practice.
Okay. All right. Yeah, now, I mean, I'm just going to move on a bit from the setup of patient's point of view. We know that you're at the forefront of the robotic revolution in the colorectal world and surgical world as well. In your opinion, how has the COVID-19 pandemic affected this ongoing robotic strategy, either in the positive or in the negative? What are your views on that?
Yeah, I think you have to remember that robotic is no different than minimally invasive approach. So laparoscopy equal robotics is pretty much the same in terms of logistics and the psyche behind, how you operate and what are the consequences. So I referred to the first document that was produced by the Royal College of Surgeons only doing open surgery. It was not all based around any evidence. It was based around a potential fear and a personal prejudice. The guy who wrote the guideline is Mike Griffin. You might know him. He's a esophagogastric surgeon from Newcastle. He worked, and he never liked laparoscopy conventionally for years. And he thought this would be the good time for open surgery to come back. So there is a prejudice to it, and since then people. The problem is there's a whole generation of surgeons who've been trained in minimally invasive approach, and they feel comfortable doing it with the approach they are more familiar with. It doesn't mean they can't do open surgery. It's just the way there's a whole generation of people who've been trained. So as April arrived, most people start doing laparoscopy, and I remember contributing in one or two publications of what steps need to be taken for minimally invasive approach, and there was no evidence. We all making it up as we go. Like we have to deflate the abdomen before we make the extraction site, and everybody has to leave the room when the extraction site has been made. There was absolutely no data to support any of that. And now as it has evolved, 3 months into pandemic or toward the end of the pandemic, so to speak, there has been not a single scientific evidence to suggest that laparoscopy or minimally invasive surgery or robotic surgery have led to higher contamination rate, for example. There was some publication initially blaming peritoneal cavity or peritoneal fluid being highly contaminated. This has all disappeared. No, people are not using, like a specialized smoke evacuation units anymore. Robot surgery may have a slight advantage in a way that operators sit much further away from it, And secondly, we use high-speed insufflator. I'm sure you guys have got it at Shaukat Khanum as well, called SurgiQuest. Makes it, which is a closed smoke evacuation system. So as you are insufflating, you can deflate in the closed circuit without exposing people. So in a nutshell, what you sort of asked me is that robotic surgery took a back seat just like laparoscopy did. But as a species, we are hugely resilient species as a Homo sapiens, and we immediately learn how to survive. Now we figured it out that actually it makes no difference. And we've all cracking on. Centers up and down the countries have started doing robotic surgery. They have started doing laparoscopy with no sort of problem, so to speak.
And I think you kind of mentioned it quite clearly there, like knee-jerk reactions to this pandemic when it first started has caused a lot more problems from a surgical perspective than solutions. And hopefully we've kind of learned from this, and hopefully when the next pandemic comes along, there won't be any knee-jerk reactions. Now, one final question before I move on to the, sorry.
Yeah, before I sort of go away, there's something that needs to remember, and I think it has a direct implication within our specialty, for example, and Shaukat Khanum is a cancer institute, for example. So one of the hidden costs of this strategies is just started to come out now. Yesterday when I was reading, I thought I better read up because you're going to ask me this. I normally don't do that, but if you look at the cancer diagnosis within UK, now there's a document released by Department of Health saying that some 200,000 patients with urgent symptom of suspected cancer, this is cancer all over, not colorectal cancers alone, they just could not get to their diagnostic test in last 3 months because they were told not to come in, diagnostic services were suspended. And at the moment, the cancer services across the country are running at 20% of their capacity. So there is a huge backlog or huge volume of people who have cancers who didn't get to the healthcare sort of system, and they would have the price to pay. So it's not so much, counting the cost of dead with COVID, is people that the whole pandemic has affected, which would have a huge implications. And that is something to be remembered, I think, in the context of Pakistan as well. At the moment, obviously, there is a huge surge and there is a huge concern, rightfully so. But at the back of it, there would be a hidden cost which most vulnerable would pay anyway, in terms of not getting to healthcare.
I think that's something I'm going to ask Dr. Khattak as well, in terms of how we've done in terms of ongoing services provision and so forth. One last question, Prof, before we move on to our next speakers. I recently came across this publication of yours regarding the global response to COVID-19. And it is basically an amalgamation of all the experiences of the European countries and so forth. Would you like to make a brief comment for our audience on that publication?
Yeah, I think most of the comments you probably have heard through David and me talking to you is to do with, making it up as you go. So initially, when the whole thing sort of broke out, I wrote to some of my colleagues all around the world, people from China, for example, Iran. They were the hotbeds at the beginning, to see how they were sort of changing their elective practice, and if this has a detrimental effect, and what we can learn, what you are trying to do now through this webinar, asking people about their experiences and then comparing it with your own practices. So, for example, within China, when there was a big hoo-ha going on, my colleagues were sort of cracking on. They were sort of doing just a PCR test, and they were operating laparoscopic cases, not open cases, because they thought there was no high risk. Recently, a group from Iran had sent me their data. 100 colorectal dissections in the month of February and March in 4 institutes, only on the basis of CT scan, not even PCR. They didn't have the PCR test, so they were just doing a CT scan and obviously clinical symptoms, with showing only 1 positive patient out of those 100 that they had done. Within UK, the publication was more focusing on, in the light of this, how can we sort of evolve, so to speak? How can we set up our own practices within UK? And that's where the CT scan, if you remember, we sort of mentioned that at the beginning we were doing CTs because that was more Chinese influence, sort of saying this is the most sensitive test. And then we moved on from there because it's a logistic issue. And then you can reliably exclude it. If people are compliant to self-isolate 2 weeks prior to coming to surgery, which I gather would be a difficult scenario in Pakistan, to do. But if they become compliant to this thing, you can easily exclude with a 48 hours before surgery PCR test as green patients. So I think it's looking at number of options internationally and trying to build up a local practice, a bit like you are trying to do.
All right, I'm good. Thank you very much for joining us for this, Prof. That's very kind of insightful. I think after hearing both of our speakers from abroad, I think our experience has been not very dissimilar. I think we've probably been a bit more pragmatic in our approach. And I would kind of move on to Dr. Shahid Khattak here, who's one of our leading laparoscopic GI surgeon. Dr. Khattak, thank you very much.
Thank you very much, Irfan.
You've obviously heard of my colleagues from the UK and their experiences in colorectal surgery and so forth. What sort of planning did Shaukat Khanum do for the GI surgeries when this pandemic started and it's evolved? And now, if you would like to compare that to what the UK experience has been.
Well, as David and Prof. Amjad has mentioned, that they were lucky that they followed Italy because they got a few weeks. We were a bit more lucky than them because already Europe and US were affected much earlier than that. So we had some, I would say, some breathing time. Initially, when we got our first cases in this country, they were obviously from the people who traveled from abroad. At that stage, the hospital decided, this is a completely cancer hospital, private cancer hospital, but they decided to help the government and take COVID patients as well. So at that stage, we had a meeting and we made a strategy for it. We were, obviously the hospital was central air conditioned, so they have to make places, negative pressure areas. And we were given, the surgical services were given 1 week to do as many electives as possible before we get COVID patient within our premises. After that 1 week where we try to get rid of as many as possible. Then we had actually phase 1, in which lasted for about, say, 2 weeks, in which we didn't do any elective work. We were doing only emergency surgeries. The main reasons were that we lost a surgical ward, we became a COVID ward. We lost a lot of our OR machines, because we built a capacity to ventilate as many patients as possible. So we did only the emergency surgeries. That was the most difficult part. But the good thing was that the hospital never stopped actually the radiation and the chemotherapy services. So we were evolving at that time, and we were planning for the next stage. So I do GI surgeries mainly. So in those 2 weeks, although I was not operating, and I'm not a respiratory or ID guy, so I was not directly involved with the COVID patient, but we did a lot of planning. For example, we do esophageal surgeries. Most of our patients, we follow the cross trial, so they are post-chemo radiation. So the good thing is that you usually have a window of operation. So obviously they were the one who were delayed, but we had a window to delay them. The next is the gastric cancers. We follow the MAGIC trial. So usually they get four cycles of chemo, then surgery, and then 4 cycles. So I actually spoke to or wrote to the oncologist about each and every patient, and we gave them another 1 or 2 cycles of chemos. The colons, we tried to do as many colons on the emergency list which we could do. The rectum, again, most of our rectums are, as Prof. know, post neoadjuvant, because we get mostly CRM threatened cases. I think that was the group which probably got affected, because what we do, we scan them MRI 4 weeks post treatment. If they have a good response, then we delay their surgery and do it at about 12 weeks or maybe later than that. But if they don't have a good response, we try to do them quicker, and we couldn't do it at that stage. So I again spoke to and wrote to my oncologist colleagues and gave them some chemo,
some more chemo
in that space
as a bridge.
And as a bridge. But now, looking back, and as these patients are coming back, I've noticed that they have progressed. So I think that was one group which got a bad deal in the whole situation. Then after that 2 weeks, we started off with the elective work, but initially it was we started with the day cases and the people who we could discharge them in a day or so, because we didn't have that many beds. So we started with the breast and head and neck and orthopedics, very little GI work. At that time, we didn't have that many testing kits as well, so we were only relying on screening. Then the next phase was when we got more testing kits, so we started as our friends from UK said, so we started doing screening 48 hours before surgery. And in that phase, which was the phase 3, I would call, we started rectal and gastric surgeries. And the last phase was obviously when we got all our ORs back. We started with pancreatic and esophageal surgery, because we got ITU back. And now we are at present, we're nearly running on our full capacity, because we have got our ITU back up, and so we're doing our esophageal. So it was actually an evolving, as they all said, it evolved in the last 3 months.
And I think it's the same, like, with the UK. First, we don't know what we're dealing with.
Yeah.
We get the resources needed to kind of set ourselves up for it, and then as our resources get better, we start opening up again. And I think that's been across the world and so forth. Now, but at what point did you decide that it was actually safe to restart all the elective surgical oncological services? And was there any guidelines that you guys used or adhered to?
I mean, as I said, you asked me that last time as well. Nothing is safe. It is just a relative term, that, and you look at the guidelines or the publications. I mean, they were about, I think in the first 2-3 months, there were 30,000 publications about COVID.
That's a lot.
So, which one you follow, I will just, if you put on the screen, there were 2 very good papers, which we discussed with our management. One was a joint statement, a roadmap for resuming elective surgery in COVID. This was from the American College of Surgeons. And another one was from the Association of Coloproctology of Great Britain and Ireland. And these two documents, I will say that they were very good, comprehensive documents. And we took a lot of things from them and then sat with our management. If can I show you the next? Can you put on the next slide? Yeah. I mean, in this in the Association of Proctology, they divided the patients into three groups. The first one are the people who are having small surgeries. I think no surgery small, but I mean which are having simple surgeries and where there was no excess morbidity if they were if they become COVID positive. But the second group is the one really, I will say more all the GI surgery come in that group, that if your patient is COVID positive, as you know, in the GI surgery, most of them will have a bit of atelectasis and respiratory complications. So if they get COVID infection, if already they have the infection, then that increases their morbidity and mortality. So you should have enough support of ICU and HDU before you start that. And if you show the next slide, and this is another where they show the environmental risk, that E1 is where the entire institution is cold. As David has mentioned, that what Britain did, that they took the private hospitals, made them cold centers, and they did elective surgery there. Unfortunately, we couldn't do that. We have one hospital, so what we did is the E2, that we segregated the services on the same site. I mean, we made it to green, yellow, and red. So the green sites were the clean sites. So before we started our elective work, we made sure that we had enough green space in the hospital where we can keep our patients. We have enough ITU beds available to us, clean ITU bed, which is at a different site from the COVID ITU. And we have endoscopy service, that if the patient needs, endoscopy at any stage post-operatively. We have a radiation, intervention radiology service, because you sometimes do need, if you get a collection or something like that. So we make sure that we have those services available before we start the major elective work, which was, as I mentioned earlier, the phase 3.
So wait, just coming back, I know Prof. Amjad has just kind of commented on the robotic side of things, and that's in the UK. I mean, they've got a well-developed system, they've got a lot of funding and so forth. Our situation is slightly different, and obviously when the pandemic started, we were following the guidelines and we like, let's not do any surgery and so forth. But how did the laparoscopic side of the GI surgery? Now, you guys do a lot of laparoscopic colorectal surgery, you also do a lot of laparoscopic esophageal surgery and gastric surgery, you do 3-stage surgeries laparoscopic before the thing started. So how did that kind of come back into play, and when did you decide it was safe to do that?
Well, as Amjad has mentioned, initially there were a lot of, no, I wouldn't call it data, but there were a lot of, I don't even call it rumors, that laparoscopic surgery is dangerous in COVID and things like that. So when you don't know that much, there's always a fear. So I have to admit that the 2 weeks where we were doing only emergency surgery, we also avoided doing laparoscopic surgery because we didn't know, But I think at that time we were doing anyway emergency. So we were not doing elective work. So I don't think so that our laparoscopic surgery had been affected at all, because in those 2 weeks, we were making stomas, and for the stomas, we just put a laparoscope, for 5 minutes and then take out the stoma. So for 13 weeks, we were not doing any major resections. But after the 2 weeks, I think the confidence was getting from the rest of the world as well. And I mean, we saw that all the, why people were talking against laparoscopic surgery was actually the smoke, which is created when you actually doing an operation, when you're using your diathermy or you're using ligature and things like that. So I personally think that laparoscopy surgery has been there for almost 30 years. It has got a lot of benefits. That's why we are doing it. So please, if there's any problem, the problem is due to the smoke. So attack the smoke, not the laparoscope. And the smoke, my feeling is that really dealing with the smoke of laparoscopy is easier than dealing with the smoke in open surgery. You know, open surgery, when you're using the dilator, the smoke goes everywhere.
Yeah.
In laparoscopic surgery, you know, it stays within the tummy. Then find a way that safely that smoke can be taken out into a container or something like that, rather than to the atmosphere. And it is much easier in laparoscopic surgery as compared to open. So if smoke is the problem, then I think laparoscopic surgery is safer than open surgery, even in COVID days. I mean, Prof is sitting there, you know, I will like it and, you know, what he thinks about it, but my feeling is very straight, attack the smoke, not the laparoscope.
Makes sense. Makes
Thank
sense. Just one last question, sir. What preparations did you recommend for the patients who are coming in for the GI surgery in terms of compared to what these guys have been doing in other countries?
Well, you know, as I mean, we have been, I mean, a lot of phone calls happen. You know, my actually junior staff, they're all the time on the phones to these patients, you know, and obviously, you know, rearrangement of the list and things like that. So they usually tell them to try to self-quarantine, but I don't know how much of that is possible. You know, maybe in Britain it would be easier, but we live in a congested houses, congested population. So then when they come in, we have exactly the same guidelines. 48 hours before the operation, we do the COVID testing for all our patients, and we don't let them in the hospital premises, you know, until the test result.
And that's more to protect the patients and the staff.
And then at entry as well, they get screening, you know, with a temperature, and they also ask the questionnaire. Oh, I'm sorry, when we actually scheduling them, we ask them questions at that time as well, our staff, that whether you have any, you know, history of fever or sore throat and things like that. And so there is a initial questionnaire, then there's a 48 hours PCR testing, and then there's again a screening questionnaire plus temperature at the time of admission. Mm-hmm. So these are the things which we follow. But I have to admit, you know, that I mean, David, their experience was different, but we have a lot of asymptomatic patients. Yeah. Because I think for the last, say, 2 months that we have been doing elective surgery, we have been testing patients. I think about 15 or 20% of asymptomatic are coming positives. So then, which cause scheduling issues, you know, yeah. Because you schedule them for an operation, they test positive, we cancel their operation, and then you have to reschedule them. And still, I mean, there's no concrete evidence that what you have to do before you reschedule. Time is I think the best, you know, that you give them 3 weeks, you know, if they've been asymptomatic in the 3 weeks, you do them.
So I'll just come back to that one question, one last question before we move on to Prof. Tariq. Those patients who test positive and are asymptomatic, and you operate on them 2 weeks down the line, have you seen any increase in the morbidity or mortality, or we are still to see what's going to happen? We don't really know what's going on.
Well, not in my patients of esophagus, stomach, or colon, but obviously, I think if you're aware, you know, one of our patients developed complications after a Whipple's operation. Yes. We lost him, unfortunately, as well. But I mean, he was COVID negative. I mean, on one test he was negative, and then on the second test he was positive.
Actually, 3 negative.
But otherwise, I've been, you know, touched wood, lucky enough that none of my postdocs have developed any. But I know you can't be lucky for that long.
You know what they say, relatively lucky in surgery. So I hope your luck stays, you know, and we carry on like this. Thank you very much, Dr. Khattak. I'm just going to move on to Prof. Latif. So, Prof, we've heard from the adult side. Now we're going to come to the pediatric side of things. Now, the pediatric surgical policies that have been put in place for the COVID, is that any different from the adult services, or they've been briefly? Would you like to comment on that?
Thank you, Irfan, and regards to everybody from UK and Pakistan. The policy was the same as was made by hospital for all the cancer patients. which means when after all the knee jerk and stopping of the surgery, when we restarted after 2 weeks, the plan was and decided that all elective surgeries will have COVID done before entering the hospital, 48 hours earlier. So in pediatric surgical patients, the policy and the SOPs were not much different than the adult surgery.
Right, right. But so if it was no different, and like Dr. Khattak said, he had some patients who tested positive or were asymptomatic. I'm sure you would have had the same experience. Would you like to comment on that side of the case?
It was a bit surprising to know that all patients, we had about 4 or 5 Wilms tumor, liver tumors, and one of the testicular. I thought the pediatric, we do COVID, they will not all be negative, but surprisingly, the asymptomatic positive patients in pediatric were almost the same as in adults, around 20%. You know that they
which is surprising.
Yeah,
because initially
it was
we thought
surprising.
children were a bit immune. Yeah.
They were asymptomatic, quite well clinically, but on test, about 15-20% turned out to be positive.
And with those patients who were asymptomatic and positive, did you see an increase in morbidity and mortality post-op in the post-operative settings?
So as per policy, we switched them off for 2 weeks, gave them time, called them back. They were still asymptomatic, and we operated on them. Fortunately, our number was not that big, but as you were involved in some of the liver ones, none of them have any post-operative problem or complication, which would be related to, say, COVID.
Yes, that's good. I mean, I hope it stays that way. But obviously, when the pandemic happened, there were some delays to the surgeries and so forth. What policy did you guys embark on in terms of the bridging side of things, and have you seen any effects of that?
Like everybody, like Prof. Amjad and Shahid Khattak, all those elective patients which we had mostly were Wilms and livers, some primary hepatoblastomas, some livers with the secondaries. And we did COVID in all of them, and those who were negative and done electively, their post-op recovery was reasonably well, smooth, uneventful. No, even the ones we did after 2 weeks after counseling who were positive with COVID did not show any effects other than which any patient would have. But their post-op recovery was uneventful and quite smooth.
Okay. And did you see any effect on the tumor maybe from the bridging therapy?
What happened initially when there was a knee-jerk reaction of stopping the elective surgery and doing the emergencies only. So we had these 4 or 5 Wilms tumors which were ready and right to be operated. But we suddenly stopped. So they were postponed for 2 weeks, 3 weeks, and they were just at that edge. They had completed their cycles and they should have been operated within a week or 10 days, but we had to delay them for 3 weeks. So like other patients, they were given and further 1 week adjuvant chemotherapy just to keep them in their place. And when they were called back when we started doing elective surgery, when we had the ICU back, I think they were pretty okay. And rather, I would say, we didn't do CT scan, repeated CT scan after this extra adjuvant chemotherapy. But clinically, when we examined them before surgery, I thought they had a more response with extra chemotherapy, and 2-3 of them had a really good response.
In terms of tumor downsizing and so forth?
Yeah.
That's interesting. So that might have been an unintended consequences of some extra chemotherapy, and so there's some good thing in the pandemic, I would suppose, for the children at least. What are your thoughts on going ahead with the pediatric oncological services and the ongoing pandemic? What are your thoughts about how this is going to progress and so forth?
Like everybody has said, there was initially a fear, so things were restricted. Like initially, I was told, try to avoid those patients who would be admission for 1 week, 5 days, or maybe 2-3 days of intensive care. So all patients were such that all needed admission like 5 days and 48 hours of intensive care. But gradually things have evolved, and we have been doing all this. I think things are settling down with all the experiences. We will continue these elective surgeries.
Just one last question, Prof, before I kind of move on to Fahad. You obviously work with Shirzad Hospital as a head of department in the pediatric sector, and now you're with us. How does the experience of you that we've had here with COVID and patients in pediatric cases, how does that compare to what is happening on the outside compared to the other hospitals?
See, Shaukat Khan is mainly a cancer hospital, whereas the other hospitals where I work, like Sheikh Zayed, they take all other patients as well.
Right.
So there were a lot of emergencies coming.
Right.
And initially not doing COVID on them because they were the emergencies. So the things were a little different. The staff was little affected.
Right.
As you know, the main surgeon, he had a positive COVID in Sheikh Zayed. So here things are much more controlled because our all cancer patients then after making this policy of being tested, but in emergencies you can't do that all the time.
True. Hopefully the situation in Pakistan will continue to, hopefully will improve, and we'll see better and better outcomes from the COVID. Thank you very much, Prof. And last but not least, I'm going to talk to our senior instructor here, Mr. Dr. Fahad Shah, who's been joining us here to talk about the training perspective during this COVID-19. Now, that is important to talk about because it's important to talk about the patients and the surgeons who are doing the surgery, but I think we shouldn't forget about our colleagues who are aspiring to become surgeons of the future. So Fahad, thank you very much for joining us.
Thank you for having me.
Now, training is a crucial part of any surgical program. What is the structure of training of surgical oncology here at SKM?
So in SKM, we have got two training programs going on. So one is the fellowship program and the other one is the residency program. So the difference in both of these is that the residency program, you are eligible after the house job and passing the competitive exam after you do the, which is by the College of Physicians and Surgeons, and the other one is a fellowship program. So the fellowship program, you do it after your residency, you have completed that and you are eligible for that then. So fellowship program that we offer these days is in surgical oncology, uro-oncology, head and neck orthopedic and gynae-onc. And the residency program, it is in general surgery at the moment. So we have got about 15 fellows and about 8 residents at the moment.
Okay, so during this pandemic, obviously there was a shutting down of surgery initially, and then things have started, and there's a lot of guidelines on doing safe surgery.
Absolutely.
How has that affected the numbers the trainees have been getting, including their exposure to laparoscopic surgery?
To be honest, as Dr. Shah mentioned, so we were not doing much work for about 2 weeks, just 2 weeks. We were doing elective surgeries, but we were doing emergency surgeries, but not the elective ones. After 2 weeks, we started slowly and gradually, increase in the number of elected cases. Initially, there were most of the consultants and senior staff members used to get scrubbed in those cases. But as our numbers picked up, we started involving our junior staff and the trainees as well. So now we are in full boom, I believe. What we were doing pre-COVID era, we are almost doing the same numbers these days.
Okay. And is there any adjunct to the surgical experiences in terms of teachings and so forth?
So initially, yes, absolutely. For those 2 weeks before, like in the pre-COVID era, we used to have daily meetings. It was almost like 3 times a week. But because of the SOPs of social distancing and everything, we could not continue with those things. So now we have adapted and we are doing morning meetings online. So we have got morning meetings of mortality morbidity once a week or once fortnightly. And then we have got online classes for the residents and the trainees as well.
Okay. And do you expect an increase in the amount of research that's going to get published?
To be honest, yes. There's a lot of data and a lot of cases that we have done so far in this COVID era, and soon we'll be having them published. pretty soon.
You're looking forward to some good publications
Thank
here.
you so much.
Now, this has been a stressful time for everybody, from the patients to the
Absolutely.
surgeons, and I'm sure the trainees have been kind of on the receiving end of things as well.
Yeah.
How have that cohort of trainees coped with this stressful situation?
To be honest, yes, as Shaukat Khanum is not a very big hospital, but it's a cancer institute, and we all like a family over here. So we try to support each other. Our seniors were very good, our junior staff, but the hospital had, supported us and provided psychological support services, and whoever needed them, they could have a consultation.
Okay. And was there many trainees who had ended up testing positive, and if they did, what was the outcomes and how was it managed?
So there was a few of our trainees that they got tested positive, but they had been coming in batches of 2 or 3.
Right.
Yeah. So it was kind of a blessing for us that not all of them got sick at the same time. But thank God, finger crossed, most of them, they're coming back to work now.
Yeah, it's good to have a nice family which can support each other and do
Absolutely.
surgical training, and I'm sure the supervisors play a very important role
They've
in
been
this
very
as well.
cooperative, yes.
Now, I'm just going to wrap this up because we're coming to the end of our webinar. What are your thoughts on the future?
To be honest, if you ask me, this thing, COVID, is going to stay with us for a long period of time. We just need to adapt ourselves and continue what we are doing.
Dr. Khattak?
Yeah, I will second Fahad. It's not pleasant to do long operations with that N95.
I agree.
So I wish that it go away quickly, but that's the wish. There's a long wish list. You don't get all of it, but I think we are getting. I have to say, humans are very adaptive. So when I did my first operation with that N95, it was awful. But we are getting more, just like I said, humans are adaptive, so we are adapting.
Prof?
Same, I think this is the adaptive, people are adapting to this thing. This will continue and we get used to that.
Prof. Chima, would you like to have some comments on the future?
Only if we knew what is future. That's the problem. So I think I'll just echo the view that everybody have said. We would adapt, and we don't have to look very far. We adapt, and that's why we are here after 250,000 years, as a species. So it would be no difference. A lot of this would be pushed or determined by the economics rather than pure healthcare. As we begin to see now in UK, for example, provision of PPE was a big issue. Now the guidelines have changed, and if the patient is in green sort of belt, as it were, operated in a green hospital, we don't have to wear N95 mask as well, believe it or not. This is the new recommendation that have come through. Now, is there a science behind it? Probably not. There's probably somebody signing the check somewhere thinking this is far too expensive. So we would adopt, we would evolve, and we would be here. If none of us in the room are here, or including myself, somebody who would probably look like us would be here.
All good-looking people, I hope. I think we've been quite lucky with the PPE here at Shaukat Khanum, and I hope we continue to provide a good quality service as you do in the UK as well and across the globe. This is obviously a global pandemic, and it requires a global response. Things are changing, things are evolving, our understanding is getting better, and with that, what was held true yesterday may not be held true today, and the same may be for tomorrow. So things are evolving, we're learning, and we will adapt as a species and survive this pandemic. Now, I will ask to look at some questions from the viewers to see if there's anybody who's got any questions coming through to us. So we've got a few questions here. The first one I'm going to put forward to Dr. Khattak is from Dr. Muhammad Ali Sheikh. Can we do laparoscopic surgery in our local setup without any filters during desufflation and insufflation?
Well, I mean, we are doing it exactly the same way as we were doing before. I mean, the only thing, as I said, when you're using diathermy or you're doing ligature, the smoke which come out, you can put an extra port, to suck out that smoke, or you do a small burst, and at the end of operation, you make sure that you suck out all the air before you make an incision for the organ retrieval.
Right. Okay. I hope that answers the question.
So not that much difference to what you were doing before.
Yeah. Same question, similar from the same person. Views regarding antibody testing in elective cases, and what about the safety of OR staff? Now, I would forward that question to Prof. Amjad Chima. I know none of us are ID specialty here, but any thoughts on that?
Yeah, I think you gotta think about why you're doing test and what test. So effectively, you want to do test to make sure that the patient is negative, so to speak, right? And we know now, even with all the data, that not single test has got 100% sensitivity. So even with a PCR, this is reported sort of 70-80% sort of sensitivity rate. And even with antibodies, we have got a serology test here in UK, and we all have been asked as a volunteer thing to go through it to pick up asymptomatic antibody carriers, so to speak, in healthcare professionals. It hasn't got 100% sensitivity still. They give us the result and then they say it doesn't mean that you are 100% positive or negative. So you got to look at your local resources, and you got to look at what is the best punt you can have. A PCR is a well-recognized way. Symptoms are well-recognized way to figure out if you have any problems. And doing it in the time window, i.e. 48 hours beforehand, is a time-tested method as it appears so far. So I think, and it also have a resource constraint. Antibody test has got expense attached to it. I know that at the beginning of pandemic, I think Spain bought $36 million worth of antibody testing kit from China. And then they realized that it's only sensitive for 30% of the population. So they were all sort of sent back. So it's a question of, if you have a lot of money and you want to find out what the money can buy you, you can buy all these expensive tests, but you would never be 100% sure.
I suppose it's very difficult to stay pragmatic, but I think we need to avoid the temptations of going overboard and stay pragmatic and practical. There's a very shocked question from one of our colleagues who's asked the question whether all the head and neck surgeons in the UK are operating without an N95 now. So, I mean, I would be a question to you, Prof, since you're based in the UK. So are the head and neck surgeons in the UK operating without an N95? From a very shocked colleague of us.
Yeah, no, I know who this colleague is probably. But I think the only head and neck surgeon I know outside Pakistan is Peter Brennan. He probably knows him as well. He's a professor in head and neck surgery at Portsmouth. And I asked him this question. And they are following the same recommendation as we are. They started off with mandatory PPE, N95 mask and everything else. And now the last sort of directive have come in, and they have given pretty much the responsibility to individuals washing the hands of the decision making, saying patient is green, you're operating in a green hospital. If you feel like not wearing it, it's your choice. So this is another way of sort of shifting the blame, as it were, or shifting the responsibility. They say that it is recommended, but if you don't feel like it's up to you.
So Dr. Raza, it is up to you. Okay, so we've got an anonymous person here asking if you've got any slides. So I will answer that question, and I think on that we'll conclude this webinar. The reason we haven't gone for a lecture-based webinar is because we wanted to keep it quite interactive, because we think it keeps the audience engaged and it keeps the speakers engaged, because the main reason for the webinar is to share the experiences of various people across the world and here at Shaukat Khanum. And rather than going for a didactic lecture where it's more reading off the slides, we want an interactive sessions where we can interact and learn from each other's experiences, and having the free flow of commentary, which I think is more interactive for a webinar than a didactic lecture. So unfortunately, we do not have many slides to share, but the ones that we do have, we will send them out.
Yeah, you're right. You see, because of this format, I could not leave my chair. Otherwise, I could have disappeared behind the slides.
We wanted to have you around for the
Yeah.
question and answer, so there was a reason for this. But anyway, thank you very much for all the speakers, Prof. From England, David, who's busy doing a liver transplant at the moment, Fahad, Dr. Hatak, and Dr. Prof. Latif. Thank you very much to all the viewers. I hope you found this as useful wherever you are practicing, and I hope this will help you provide better surgical care in the unit that you're working for your patients. Thank you very much. If there's any feedback, please do feel free to kind of share that with us to try and make this any better than we have already done. Thank you so very much. I'll sign off now.
Thank you.
Thank you.
Thank you. Thank you, Prof. Bye.